Hi, this is Dr. Pierce Talsma, and I'm here today to talk to you about spinal mechanics. So learning objectives for today, we're going to identify some important spinal anatomy, talk about what flexion, extension, side bending, and rotation are, and describe Fryet's principles. There are two different types of motion in the spine, type 1 and type 2 motion, and we'll define those, as well as looking at locked open and locked closed facet joints, and what sorts of muscular restrictors affect type 1 and type 2 motion. We'll also discuss viscerosomatic reflexes and how they might cause type 2 findings in the thoracic spine. So let's look at a case. My favorite friend, Napoleon Dynamite. He's a 17-year-old male. He has some thoracic back pain going on for about 3 days. It's a 7 out of 10 dull ache. It's non-radiating, and it began when he was attempting to take his friend Pedro's bike over a sweet jump. He initially also had some groin pain, which has since subsided. He has been trying some Tylenol, which helps a little bit, and using a heating pad, and both are helpful. Back bending exacerbates his pain, makes it a lot worse, and forward bending makes it better. He has no paresthesias, weakness, bowel or bladder changes. Allergies to penicillin and eggs, which he discovered incidentally after working a summer job. Medications include Zyrtec for allergies. Past medical history are for allergies, asthma, and dry lips, for which he sometimes uses chapstick. He has never had any surgeries before, and he lives with his grandmother and his brother Kip, and he enjoys drawing magical creatures such as a liger. He's a non-smoker and he denies alcohol or illicits. Family history is significant for hypertension and diabetes, and review of systems is otherwise negative. Physical exam. General. He is a well-nourished male of appropriate stated age. His heart and lung exam are normal. His neuro exam, which you always want to do in someone who has back pain, specifically low back pain. So his deep tendon reflexes are +2 out of 4, equal and bilateral in the upper and lower extremity. You also always want to check upper and lower extremity because they can tell you different things about what's going on in the nervous system. Like if they were hyporeflexic in the upper extremity but hyperreflexic in the lower extremity. Sensation is intact, there's no clonus. The toe is down going on Babinski. Strength is intact, +5 out of 5. A straight leg raise is negative. Lermit's exam is negative, and he's able to heel and toe raise evenly. His gait is normal, non-antalgic, non-myelopathic, which means it doesn't appear painful. His gait doesn't have any abnormality to it, and there is no foot drop, which indicates normal strength of his ankles and dorsiflexion. Musculoskeletal, on spinous process percussion, it's negative, and there's no scoliosis, no increased lordosis or kyphosis. He does not have any CVA tenderness, again checking for any kidney abnormality, and his stomach, the bowel sounds are positive, it is soft and untender. So GI and GU things can refer to the low back, so you always want to be sure to check them. You also want to be sure to look, so his skin is warm and dry without any rashes, no cuts or bruises. So you want to evaluate the extent of his injury and also find out what else is going on there. So then we're going to do an osteopathic structural exam, which you guys have already done in your class. So you see that his right shoulder is elevated, right scapula is elevated, right iliac crest is high, greater trochanters are high, knees are level, ankles are level, and he has good arches. Head OA is extended, side bent right, rotated left. AA is rotated right. He has some findings in his cervical spine. He also has some findings in his thoracic spine and in the ribs, in the lumbar spine, hypertonic paraspinal muscles, sacral diagnosis, and pelvic diagnosis. So I think what is interesting here is that all of these things that you don't understand the nomenclature for, so for head here, for neck here, for thorax here, are all brand new diagnoses to you that you will be able to understand exactly what that means by the end of this lecture. The other things, including sacrum and pelvis, you'll get later on, and you will understand all of this by the end of your first year. So looking at just some really significant spinal anatomy, so there's 26 segments, 7 cervical, 12 thoracic, and 5 lumbar. And the important anatomy to look at here are some of the ligaments, right? So you have your anterior longitudinal ligament, and you have your posterior longitudinal ligament back here. And you have your facets, which are where the superior and inferior articulating processes come together. And that is a joint. It actually is a joint space. It has synovium fluid in it, and it's lined with cartilage. So those joints move in a very particular way, and those are really important to understand their motion because that is what is going to drive the spinal mechanics motion, the specific Facet principles we're going to learn about in just a minute. All right, here are your transverse processes. Here we're looking at it from the posterior side, so you can see the spinous process here, and then you have your facet joints here. Again, these are what's going to drive spinal mechanics motion, and that's why we make such a big deal about understanding them. So orientation of the facet joints is what rules and governs what kind of motion can happen. So in the cervical spine, you can see that they're at an angle which is different than the thoracic spine or the lumbar spine. So in the cervical spine, they're backward, upward, and medial. You can remember that as BUM. They're 45 degrees to the transverse plane, and they allow for flexion and extension and lateral flexion and rotation. So that's why the cervical spine has so much motion. It's because you can see it can really move about this plane and this plane. The thoracic spine is backwards, upwards, and lateral. It's 60 degrees from the transverse plane, and it allows for lateral bending, rotation, and some flexion and extension. The thoracic spine is also limited by some of the rib motion. Finally, there's the lumbar spine, which is backwards, facing backwards, and medial. You can see it's pretty much straight up and down, backwards, and then out at a medial angle. It's 90 degrees from the transverse plane and 45 degrees from the frontal plane. So there's no rotation here, and it does primarily flexion, extension, and some lateral side bending. The LS junction does allow more rotation as the facets are more oblique there. So that's a transitional area, which makes it a little bit different. So as I said before, the facet joints are responsible for the characteristics of motion. So they restrict the mobility of the intervertebral movement, and they define motion coupling characteristics. So it's because of how they orient to each other that motion is coupled. So they're in control of the spine, and they govern rotation and side bending. So even though we're describing today mechanisms and laws in which we say this is how the spine moves, and this is how the facets move, and this is how the vertebrae move, your patients don't read the books. So sometimes you'll find things that don't always go along with the rules. And these pictures are some of the things that illustrate why they don't go along with the rules. So if you have facet joint hypertrophy, so if you look at this picture here, you might have an arthritic facet. So you get bony changes, maybe bony spurring, the ligaments get big and can get buckled, which is going to limit the motion at that facet joint and may cause it to move in a different pattern than what we would expect. Here in these vertebrae, this is an X-ray, and you can see spurring from one vertebrae. This is the anterior body of the vertebrae. You can see spurring from one to the next. Spurring in osteophytes like that could also change the motion of vertebrae. Here you can see a picture of facet tropism. Tropism just means that the facet joints face in different directions and they only move with great stress. So on one side here, right here, you can see this is the inferior articulating facet meeting with the superior articulating facet of the one underneath. And that looks like a pretty nice facet joint. And then you look over here and those don't meet together very well. They aren't oriented as well as they should be. And so that is going to change the mechanics there and may alter the way that vertebrae moves, potentially leading to early arthritis. It's actually a very common problem in the lower lumbar spine. Also, you can see down here there's lumbarization and sacralization. This would be sacralization of the lumbar spine. So obviously these two segments are going to move much differently than what you would expect normal segments that don't look like that. And you'll find those more often than you think that you would. So a few of the rules to remember. You have to remember the thoracic vertebrae rule of 3. And that's that T1 through 3, the spinous process is at the same level. T4 through 6 is a half below. T7 through 9, 1 full level below. T10, 1 full level below. T11, a half, and T12 is at the same level. And this is going to be really important because as you're trying to diagnose, we're going to ask you specifically what level vertebrae that you're at. So in order to know that, if you're counting spinous processes, you can see how you might be on the spinous process of the one below when you're really on this vertebrae here, but you call it this one because you're counting. So you have to know where the spinous processes are and where the transverse processes are. That's why those rules are very important. So when we're talking about spinal mechanics, it's important to think about what's actually restricting the motion of these vertebrae. And oftentimes it's muscular restriction. So long muscles, superficial back muscles, can do long restrictions. They're the long restrictors. and we'll talk a little bit more about them in a minute, but these are more of the superficial back muscles. They usually help with upper extremity motion. They're things like trapezius, latissimus, even rhomboids and serratus anterior are considered longer muscles than what we're going to talk about as the short restrictors. So these usually span 2 or more joints, so they have an effect on a larger portion of the spine. If you look a little bit deeper, you have the intermediate muscle group. These span 2 to 8 segments. They are also long restrictors, and when they contract as one, they typically side bend, and when they contract together, they extend. And these are the multifidus, semispinalis, longissimus, iliocostellus, even lower into the quadratus lumborum and psoas major. So they can also cause long restrictions of large groups of vertebrae. Then you have your short muscular restrictors. So these are deep segmental muscles. These are things like interspinalis, rotatories, brevis and longus, and levator castorum. And they usually affect a single vertebrae. So these muscles are really important. They have a lot of proprioceptors in them. So they're the ones that are helping to tell your spine where it is in space and to adjust our posture and to adjust in gravity. So they're really making a lot of fine-tuning changes. So these muscles serve to balance the spinal column in response to larger movements from the long restrictors. So they're actually really important in spinal position. You can also have viscerosomatic reflexes. So this is just a very general overview in viscerosomatic reflex, but generally what is happening is that it's in response to an irritation of a visceral organ. So you have a pain signal from the organ, and it goes to that spinal level, and it sensitizes the spinal level. So that spinal level then sends a motor effect out, which can cause muscular changes. So if you have the facilitation coming in here from the ventral input, it can go out at the same level via the dorsal horn. So you have facilitation at this level from lots of information coming in. And there's not necessarily differentiation between what's going to go out to either the sympathetics or to the organs and what's going to go out the dorsal ramus to go to the paraspinal muscles in the back. These can cause tart changes in the thoracic spine, including bogginess, tenderness, and restricted range of motion at that segment, and change in paraspinal tone. They typically relate to very specific areas. So if you're looking for heart sorts of changes or reflexes coming from the heart, that would be from T1 through T5, and from the lungs might be from T2 through T8. So we can use the information that we find from our tart changes to help diagnose things that might be going on in the organ system. And additionally, by treating what's going on in the paraspinals and in the spinal region, we can have an effect on defacilitating that spinal column by having further somatic information go into that area. So points of reference. When referring to a single vertebrae motion, it is described in relationship to the one below it. So T3, we're specifically talking about T3's motion on T4. And a vertebral unit includes the 2 adjacent vertebrae, their associated disc, their joint, so arthroidal, ligamentous, muscular, vascular, neural, and lymphatic elements. Okay, and the motion is described in terms of the anterior superior body. So we're naming for where this moves to right here, which can be kind of confusing for people because they often want to name it for where the spinous process goes, which would be the opposite of this direction. So you can imagine if this rotates to the right, the spinous process would move to the left, and vice versa. If this rotates to the left, the spinous process would rotate to the right. So we're always naming it for where is the very front part of that body of the vertebrae going to. So let's talk about flexion and extension. So there's forward bending and backward bending. And again, we're always naming it for what's happening to this part right here and what's it doing in relationship to the vertebrae below. So when you have forward bending, you have your anterior longitudinal ligament is more lax. So recall that we looked in the beginning, anterior longitudinal ligament runs along here. And you can imagine how that becomes more lax as it's bending forward. There's more pressure on the posterior elements, and the inferior facets open. The inferior articulating facet lifts up off of the superior articulating facet here. So these open. That's a very important concept moving forward. For backward bending, you can see that the anterior longitudinal ligament would get more tense, the posterior longitudinal ligament would have some slack to it, and the facets would close. They would come closer together. So the inferior articulating facet of the top vertebrae and the superior articulating facet of the bottom vertebrae would become closer together. If you start to memorize that right now, you'll really help yourself. What happens in flexion? Facets open. What happens in extension? Facets close. So we've talked about flexion and extension. Now what's happening with side bending and rotation? So rotation is always coupled with side bending, except at the atlantoaxial joint. So there's always only rotation at the AA, right? Remember the dens and how it fits into the space there. So it only does rotation. Everything else has side bending and rotation. So you can see this body is rotated to the right, and here's the normal view, and then here it's rotated to the left rotation. And again, that helps to show you that the body and the spinous process are moving in opposite directions. So don't get confused with that. We're naming it for where the front body is. Side bending is almost always coupled with rotation. So if it's side bent to the right facet joint will close and the left will open. So you can see here's normal. If it's side bending to the left, the facet joints on the left side will close and on the right side will open. If they side bend to the right, they will close on the right side and open on the left side. And keeping in mind, when we say things are in neutral, that doesn't mean it's straight up and down. So neutral in the world of spinal mechanics is not a single point, but a range in which the weight of the trunk is borne on the vertebral bodies, the discs, and the facets are idling. So neutral just means that the facets are neither open or closed. It's not that they're in a straight line, because we have these normal spinal curves, right? We have the lordosis of the cervical spine, the kyphosis of the thoracic spine, and the lordosis of the lumbar spine. So it's not a straight up and down picture. All right, so let's move into Freyat's rules for spinal motion. Type 1 mechanics. When the thoracic spine and lumbar spine are in a neutral position, side bending and rotation are coupled in opposite directions. So if it is side bent right, then it rotates to the left. And if it's side bent left, then it rotates to the right. The other thing that I want to point out here is that we said in the thoracic and lumbar spine. This does not happen in the cervical spine because the cervical spine has another joint which helps to govern its motion, which is the oncovertebral joint. So type 1 mechanics, when they side bend and rotate in opposite directions, are only in the thoracic and in the lumbar spine. As you can see from the picture here, there is right side bending. So you're going to get this nice C-shaped to the right side. And you can see the vertebrae are rotating to the left side. So they are in opposite directions. So type 1 mechanics, which we call neutral mechanics. And I like to put this little N here and have the arrows pointing in opposite directions, which reminds me that side bending is in one direction and rotation is in the opposite direction. So these are usually groups of vertebrae, 2 or more. That being said, every once in a while you can find one that moves in neutral mechanics as just one, but that's a rarer occasion. Okay, these are usually caused by the long restrictors. Remember we talked about those long muscular restrictors, the iliocostalis, longissimus, spinalis, trapezius, all of those big long muscular restrictors. They side bend and rotate to opposite directions, and they tend to be compensatory curves. So we're going to learn about type 2s next. But if you find a type 1, you should look above and below and find out if there is a type 2 that's setting it up, right? They're usually in response to something. The side bending component is the most significant part of this. So that's the part that you want to treat. And they're found in neutral. So we're going to learn that when we diagnose these, you're going to have your patient flex forward and extend back. And when you look for these specifically, they will be found in neutral when people are just sitting there in a normal spinal position. So what causes these? Well, repetitive strain, doing things over and over again, potentially the way that you sit, the way that you stand. You always have one leg crossed over the other. You'll always do one-legged standing. Maybe you work in a factory line and you're always twisting to a certain direction. So it can be repetitive things over and over and postural issues. Secondly, it can be due to compensation. So the goal is always to keep your eyes level. So if you have somewhere else, maybe like a short leg or your pelvis is unlevel, then you may have a compensatory type 1 curve, which is going to bend things all the way up so that your eyes can remain level. Type 1 mechanics can also be caused by rapid stretch followed by reflexive contraction. So those big long muscles, if they contract, it can cause these type 1 type mechanics. And they're often misdiagnosed as muscle hypertonicity or spasm. People will feel and say, oh, that muscle is really tight. And really what you're feeling is that the transverse processes underneath are pushing through that muscular belly in a big group. So it feels like muscle hypertonicity, but you have to feel through that to really feel for those transverse processes. So now moving on to type 2 mechanics. Remember, type 1 was in neutral. Type 2 mechanics is in flexion and extension. Side bending and rotation are coupled to the same side. So this time they're going in the same direction. So if a segment is side bent right, it will also be rotated right. And if it's side bent left, it will also be rotated left. So I like to use the flexion and extension right here. So they are both pointing in the same direction. So remember, neutral was pointing in opposite directions. Flexion and extension are pointing in the same directions. So they occur in flexion or extension. They're usually single segments. Again, it could happen in 2 segments or 3 seconds, but that's usually not the case, and that would be pretty rare. They are typically due to the short restrictors. So remember those little tiny muscles that have to do with proprioception and helping to make sure that the spine is in proper alignment? Those are the ones that would be causing type 2 mechanics. They're also due to the Facet model. So the Facet model are telling you if facets are locked open or locked closed in flexion or extension. So the facets are really the ones that govern these type 2 mechanics. Remember that they side bend and rotate in the same direction, and these are considered non-neutral. They're usually traumatic, so it's usually to an acute trauma, or it can be due to a viscerosomatic reflex like we talked about earlier. They are always found in flexion extension, and flexion extension is the primary problem. So finally, type 3 mechanics, and really it's the type 3 rule. It's not necessarily mechanics. But what it says is that when you initiate motion of a vertebral segment in any plane of motion, it will modify the motion of that segment in other planes. So if you start to induce flexion or forward bending, it's going to limit how much side bending and rotation there is. So what I want you to do right now is sit in your chair and go ahead and rotate to your right. So bring your body over to the right side and now rotate to your left and see how much rotation you have. Now go ahead and side bend to your right side and then try and rotate. You can't rotate as far. And how about if you side bend to the left and then try to rotate? Your rotation is going to be limited. So when you induce a plane of motion, the other ones will be limited. And that really comes into play when we do our treatments. Sometimes to do a treatment, we don't need to take up all planes of motion, flexion, extension, side bending, and rotation, because as soon as we take up 2, the third is already going to be limited. So where do these motions occur? At the OA, you have type 1 mechanics. So that would be side bending and rotation in the opposite directions. C1 through C2, so that would be AA, would be rotation only. C2 through C6 has type 2 mechanics, side bending and rotating in the same direction in type 2 mechanics. And then C7 through L5 will be type 1 and type 2 mechanics. So you can have either one all the way from C7 down. So how are you going to diagnose these mechanics on your patient? Well, first you're going to do your scanning exam. So you're going to start by looking at gait, posture, range of motion. What does it look like? If you really learn to look at your patients, sometimes you can see these large group type 1 spinal curves in the spine. Then you're going to do your screening exam, which is your light palpation, and you're going to look for TART changes, right? You're going to look for tenderness, asymmetry, restricted range of motion, and tissue texture abnormalities. And through your screening exam, it's going to help you identify an area that isn't moving so well. When you identify that area, you're going to want to go in and do a very specific segmental exam, which is what we call the 3-positional diagnosis, and which we'll be going over today. So scanning starts with gait, looking at posture, looking at active range of motion and passive range of motion. So in the spine, again, that's flexion, extension, side bending, and rotation. Are there any skin markings? Do they have any rashes or lesions? Do they have abnormal spinal curves? Do they have scoliosis? Are there things there that are already going to inhibit or limit the range of motion that their spine has. And then you can have them do a forward bend test, which helps to screen for scoliosis, right? You'd see that rib hump as they bend forward, which would indicate a spinal curve. On your screening exam, you do light palpation. You could look for step off, which would look for spondylolisthesis or stepping forward. You can look for your tart, which we described already. You do bony palpation, so you'll feel for transverse processes and spinous processes. You can do ligamentous palpation, muscular palpation for the short and long restrictors. You can do percussion over the spinous processes, checking for fracture. And again, of course, CVA tenderness, always looking for those other issues that could be causing back pain. So palpable muscle hypertonicity of the deepest muscle layers, including multifidus and levator costalis, is pathognomonic of vertebral motion segment dysfunction at that level. So when you have muscle hypertonicity going on there, you need to look a little bit deeper and think about what's going on. So also looking for your tissue texture abnormalities, including skin drag, right? Feeling that difference in the texture of the skin, a red response that doesn't go away, a coldness or a bogginess that just feels kind of like edema or swelling. So once you've done those things, they're going to help narrow in, well, where do you need to do your segmental exam? So you've found an area of dysfunction, and now you're going to check its motion in neutral. So just where you found it, probably with them just sitting straight up. You're going to check it in flexion by having them bend forward. So usually you have them start by dropping their head forward and rounding forward. And then you're going to check it in extension. So that's why it's called a 3-positional diagnosis. You're in neutral, flexion, and extension. And then that will help you make your diagnosis. So here is a picture. The middle picture is going to be your extension. So here's your neutral, just straight up and down, normal spine. The arm is only elevated so that you can see the spine adequately. This is going to be extension. See how he's extending backwards? And here's going to be flexion, rounding forwards. So diagnosing and naming. The diagnosis is always named for the position of ease. So which way does it like to go? Where does it want to be? And what makes it most symmetric? So for 3 positional diagnoses, you have your neutrals, which are going to be type 1 mechanics, and they're going to be a group curve. You have your flexion, which are going to be type 2 mechanics, and those would be extended lesions. You will find them in extension, but they will be flexed. And then you have your extension lesions. Again, type 2 mechanics, side bending and rotating in the same direction, and those would be flexion lesions, which means they cannot flex. But you name it for where it wants to go, for what makes it feel better. So type 1 mechanics are neutral. So you're going to feel this restriction and prominent transverse processes from T3 through T7 on the left. It's most prominent in neutral. So you have the patient flex forward and it doesn't get any better, and you have them extend and it doesn't get any better. So the position of ease is in neutral. It is a group, and you feel it on the left side, so it's rotated left because you feel those transverse processes coming out at you, and it's side bent right. Your restriction barrier, so this is the barrier, is going to be flexion or extension, right? It would be either one. It would be a group. It would be in right rotation and left side bending. And here's how you name it. T3 through 7, neutral, because we found it in neutral and there wasn't any change in flexion or extension. Side bent to the right, lowercase r, rotated to the left. So that's what that means. And again, this is the position that it likes, the position of ease. It likes to be in neutral. It likes to be rotated right. When you feel the transverse processes through T3 through T7, you feel all of those transverse processes rotated to that side. They're sticking out at you. That means that the body of it is rotated to that left side. So type 2 mechanics are extended, or this is the example for extended. So the position of ease, where does it become more symmetric? So if you find a transverse process at T3 on the right, you find that it's a single segment. It has non-neutral mechanics, meaning it gets better in extension and it gets worse in flexion. So then side bending and rotation are coupled to the same side, and that's going to be extended. Why? Because we name it for where it wants to live. It gets better in extension. It feels more symmetric. It gets worse It sticks out more at you in flexion. So the naming is going to be T3 extended, we name it for where it wants to live, side bend, rotated, right. So type 2s are found in the position of the restriction. So it's found in flexion. That is where it doesn't want to go. It really sticks out at you. It's named for the position of ease. Its barrier is going to be in flexion, side bending left, and rotating left. And finally, we have our type 2 mechanics flexed. So if we feel something at the transverse process on the right at T3, it's a single segment, it's just T3, and it has non-neutral mechanics, so it gets better or more symmetric in flexion, and it gets worse in extension. That transverse process really sticks out at you more. Side bending and rotation are occurring in the same direction, and they are flexed. So for naming, it's going to be T3 flexed, F, rotated, side bent to the right. It's found in the position of the restriction, which would be extension in this case. It's named for the position of ease, where it gets more symmetric. And its barrier is an extension, side bending left, and rotating left. So the Facet model of type 2 mechanics. Why do the type 2s do what they do? So again, going back to the Facet model, facets close with extension and they open with flexion. This is probably the toughest part of the concept to think about when you're thinking about spinal mechanics. And if you always come back to this model, it's going to help you remember what to do. So if something interferes with the capacity of a facet joint to open or close, restriction of motion of either forward or backward bending will result. Okay, so facets have to be able to open when you flex forward, and they have to be able to close when you extend backwards. So what happens in type 1 mechanics is that one of the facets will become either locked open or locked close. So you can imagine if only one got stuck, that would really mess up what's normally happening with opening and closing. Let's look at what that would do. So with type 2 mechanics extended, what you will feel, you'll feel one segment. It will get better in extension, and the transverse process will feel more prominent, or it'll feel worse in flexion. So what's happening here? So remember and ask yourself, what do facets do when they extend? Will they close? So if it gets better in extension, that means that your facets can close normally. Okay, stop right there. You already know. Something is locked closed. That's your answer. It cannot flex open. So rotation and side bending occur around the locked closed facet. So let's say it's on the right side. As you extend, it can close. As it tries to open, if the right side is locked closed, the left side is going to be able to open and twist and turn and do what it can to be able to flex forward. Okay, so rotation and side bending are going to occur around that locked closed facet. So when the spine is extended, all the facets close and you have symmetry. When you try to have the patient flex, they hit a restrictive barrier. One side can't flex forward. So side bending and rotation occur around the closed facet. So here is a picture of this. Here you have your right facet is going to be locked closed. So when they extend backwards, both of your transverse processes will seem to come back evenly and equally. Why? Because these can both close just fine. When it tries to open, this one stays locked closed, but your left one is allowed to open. So as this vertebral body starts to flex forward, it's going to side bend and rotate over to the side. So this transverse process will feel more palpable to you. Okay, so the right transverse process will feel more posterior. And that's what this picture is trying to demonstrate here. As it's flexing forward, it's going to side bend. See how this side is closer together, so it'll side bend to the right. It'll also rotate to the right because it's rotating around this. This one can't open, so it just stays stuck where it is. So let's look at flex for a second. Again, you will feel a single segment. It'll feel more symmetric at the transverse processes in flexion, and it'll feel worse in extension. So what's happening? The facets are stuck open, right? So stop. Remember, if you find it in flexion, what do facets do in flexion? They open. So something is stuck open. It can flex, so when you move into flexion, they move symmetrically. but one of them can't close. So when it tries to close, one will come back normally and the other one won't. So it'll side bend and rotate around the closed facet. Just like we saw before, they're always side bending or rotating around the closed facet. It's just which one is stuck. So again, if we say that the left facet is locked open, so again, we have this person flex and round forward, and we find even motion at the transverse processes. Well, that's fine. They can both open. They move normally in flexion. When you have that patient extend, this one can come back, but this one can't. This one stays stuck open. So the same thing is going to happen. It's going to side bend and rotate around this side. But really the problem is what's going on right here. This is stuck open. There's a gap right there. But this side can try to extend back. So when it does that, it'll side bend and rotate around here. So this transverse process will feel more prominent. Finally, there's also bilateral facet motion. So you can have both facets stuck open, which would be considered bilaterally flexed, and you can also have both facets stuck closed. The thing that you'll notice here, you're like, I'm not really finding any type 2 mechanics here. I'm not feeling side bending or rotation at the transverse processes, is sometimes you'll feel this. If it is stuck open, bilaterally flexed, you'll have a greater interspinous distance here. If it's stuck bilaterally extended, you'll have a smaller interspinous distance here. Why? Because both facets on both sides will be stuck. So why does vertebral motion dysfunction happen? Well, it can be entrapment of synovial membranes that are within. Remember we said those facet joints are a true joint. They have synovial membranes and they're an enclosed joint space. It can also be alteration of normal tracking patterns. So those facets can get a little bit off track, if you will. It can result in smooth gliding surfaces becoming lost or becoming sticky. There can be restriction of motion due to alteration in muscle tone, or altered biomechanical properties due to fascial restrictions, that joint capsule, ligamentous structures. We talked about how you can see arthritis things, bony changes. Those are all going to limit vertebral motion dysfunction. It can also be due to trauma, arrested physiologic motion, and postural compensations, like we talked about before, things that make our body have normal and sometimes not so normal changes in them that we have to compensate for. And these typically happen more common in the transitional areas, like the CT junction, like the TL junction, like the LS junction. Why? Because you have different kinds of mechanics and different shapes of the vertebrae that are happening there that are going to influence their ability to have motion. So exceptions to vertebral motion rules: single plane dysfunction, areas that have compression, areas that have had trauma, advanced degenerative disease, and congenital abnormalities. So like we said, these things are going to make it so that the normal vertebral motion you would expect to find don't happen. So if you get out and you're testing someone out and it's not moving the way that you think it should, they may have one of these things that is influencing that. So let's do a little bit of practice. So you have type 1 mechanics review. Would it be a group or a single segment? Would it be a long or short restrictor? Would it be found in flexion and extension or neutral? Would rotation and side bending be on the same side or opposite sides? Traumatic or compensatory? So type 1 would be in a group. They would typically be due to long restrictors. They would be found in neutral. Rotation and side bending would be to opposite sides, and they are typically compensatory. So you palpate your patient's back, and you find fullness on the left side from T5 through T9, and you find it in neutral. It stays the same in flexion and extension. What can you say about this dysfunction? So the answer is this is a neutral somatic dysfunction, type 1. It's a group. You find it in neutral. There's really no change or worsening in flexion or extension. You palpate your patient's back and you feel fullness on the left side from T5 through T9, and you find it in neutral. It stays the same in flexion and extension. is easier to side bend your patient to the right? How would you name it? So the answer is T5 through 9, neutral, side bending to the right, rotation to the left. So again, you feel it on the left side. Those are the transverse processes coming out at you, indicating it's rotating that way. So that's why you feel the fullness on that side. You palpate your patient's back and you feel fullness on the left side from T5 through T9, and you find it in neutral. It stays the same in flexion and extension. So what are its barriers in? So its barriers are in left side bending and right rotation. Remember, it's in neutral, so flexion and extension aren't really playing a role here. And if we're thinking about type 1 mechanics, the biggest part of the dysfunction, correct, is the side bending. Type 2 non-neutral mechanics review. So would these be a group or a single segment? Would they be long or short restrictors? Would they be found in flexion and extension or neutral? Would rotation and side bending be on the same side or opposite sides? Would it be traumatic or compensatory? So for type 2 non-neutral mechanics, they would typically be single segments. They would usually be caused by short restrictors. They would be found in flexion and extension. Rotation and side bending would be to the same side, and they are usually traumatic or caused by viscerosomatic reflexes. You palpate your patient's back and you feel fullness over T4 on the right. It gets better in flexion, meaning that the transverse processes are more symmetric, and worse in extension. What would you consider this? The answer is flexed. It gets better or more symmetric in flexion. And again, we always name it for where the position of ease is, or where that segment likes to live. You palpate your patient's back and you feel fullness over T4 on the right. It gets better in flexion, the transverse processes get more symmetric, and worse in extension. What type of mechanics would this segment have? The answer is type 2, side bent and rotated to the same side. And that's because there are changes in flexion and extension, right? It wasn't found in neutral. You palpate your patient's back and you feel fullness over T4 on the right. It gets better in flexion, this transverse processes get more symmetric, and worse in extension. There's also more ease to side bending at T4 on the right side. How would you name it? So you name it T4, flexed, because that's where it gets better, rotated, and side bent to the right. So you're naming it for where it lives. You palpate your patient's back and feel fullness over T4 on the right. It gets better in flexion and worse in extension. What are its barriers? So if it is flexed, the barrier would be in extension. If it is side bent and rotated to the right, then its barrier would be in left side bending and rotation. These concepts are very important for you to know where the barriers are, because a lot of the treatments that we use to treat spinal mechanic issues have to do with putting the patient into either position of ease or into the barrier. So again, spinal mechanics review. Type 1, found in neutral. No change or no symmetry found in flexion or extension. They're usually multiple segments, long restrictors, rotation and side bending are to opposite directions. They're usually compensatory, and their naming is going to be neutral, side bent left rotated right, or neutral side bent right rotated left. Type 2 are found in flexion or extension. They utilize the facet model of motion, so whether a facet is stuck open or stuck closed. They are usually due to short restrictor muscles. They're usually single segments, and rotation and side bending are to the same side. They're usually traumatic or viscerosomatic, and they're named for their position of ease. So they're usually extended, rotated, side bent, or flexed, rotated, side bent, and then it can be to the left or to the right. So, final set of questions. You palpate your patient and you feel a fullness at T8 on the left side. It gets worse or more prominent in flexion and better or more symmetric in extension. You note that it is easier to side bend the patient at that level to the left side. What is the position of the segment? So that segment, when it gets better in extension, you name it extended, rotated, side bent left. So the rotation is because you felt it on the left side, a fullness on the left transverse process. And also you can side bend it, and it side bends to the same side there. So you know type 2 mechanics. You palpate your patient, you feel fullness at T8 on the left side. It gets worse or more prominent in flexion and better or more symmetric in extension. What is its barrier? So the barriers are going to be in flexion, so the opposite of extension, and side bending and rotating right. Those are the directions it does not want to move to. You palpate your patient and you feel a fullness at T8 on the left. It gets worse or more prominent in flexion and better in extension. Which facet is locked open or closed? So again, when you're thinking about this one, we said that this is more symmetric in extension. What do facets do when you extend? They close. So you're thinking that probably I have one locked closed. Now which one is it? So the answer is that the left facet will be locked closed. And that is because as you have the patient flex forward, the left side cannot open. So it's going to side bend and rotate around that closed facet. So type 2 facet model review. You palpate your patient, you feel T8 transverse process more prominent on the left. It gets worse or more prominent in flexion. It gets better in extension. So what is the position of that segment? Well, the position is going to be extended, side bend, and rotated left. So then what's its barrier? Flexion, side bending, and rotation right. And how would you name it? T8 extended, rotated, side bent left. Then would the facets be locked open or locked closed? Again, remember that when you extend, both of your facets close, and when you flex, both of them are open. So if it's extended, what's happening to one of the facets? It'll be locked closed. And which one will be locked closed, the right one or the left one? It would be the left one. You palpate your patient and you feel T5 transverse process prominent on the right. It gets better, more symmetric in flexion, and worse or more prominent in extension. What is it? So it's going to be T5 flexed, which is where it gets more symmetric, rotated, side bent right, because you felt the transverse process more prominent on that right side, meaning that that body is rotated that way. You palpate your patient, you feel T5 transverse process prominent on the right. It gets better or more symmetric in flexion and worse or more prominent in extension. What are its barriers? So the answer is going to be extension, side bending, and rotation left. So if it gets better in flexion, its barrier is extension. And if you know that it's rotated to the right and side bent to the right, side bending and rotation to the left will be your barrier. So you palpate your patient, you feel T5 transverse process prominent on the right. It gets better, more symmetric in flexion, and worse or more prominent in extension. So again, the diagnosis being FRS right. Are the facets locked open or closed, and which one? And again, stop and say, what's my diagnosis? Flexed, rotated, side bent right. So what happens to facets in flexion? Do they open or closed? So the answer is there is one that is locked open. So in flexion, facets open, and the one on the left, because remember, it's going to side bend and rotate around the closed facet. So if you always remember that it side bends and rotates around the closed facet, whether it's a closed facet that's stuck or whether it's an open facet that's stuck. It'll help guide you to making a correct diagnosis. So facet model review. You palpate your patient and you feel the T6 transverse process more prominent on the right. It gets more prominent or worse in extension, and it gets less prominent in flexion. Feeling it on the right side helps indicate that it's rotated that way, and you can also side bend it and you find that it also side bends to the right side. So what is the position of the segment? It would be flexed, side bent, rotated right. So then what are its barriers? There would be extension, side bending, and rotation left. Then how would you name it? T6, flexed, rotated, side bent right. And then will the facets be locked open or closed? Again, look at if it's flexed or extended. The facets will be locked open, it's flexed. And which one will be locked open or closed? The left one will be locked open. Again, it's going to side bend and rotate around that facet, which can close. So this is my favorite mnemonic in the entire world. Ek, fu. Doesn't mean anything. You just have to memorize it. So ek stands for if you have a segment that is extended, the side that you feel the transverse process on, so say it's a left side, that would be your common side. That would be the side that's closed. So when your segment is extended and you feel as the patient flexes forward, you'll feel it on the side that's locked closed. Fu means flexed. So if you have a segment that is flexed, it means that the opposite side from the transverse process that you feel is going to be open. It refers to the side opposite that you feel the transverse process on prominently. So remember, you're talking about two different things here. The extended and closed and flexed and open refer to the facet motion, and the common side and opposite side refer to the transverse processes that you're monitoring as you're having your patient flex forward and extend backwards. So back to our case. We see we have our friend Napoleon, and now we can look at this and we can understand what these things are saying. So we now know that at his OA, it's extended, side bent right, rotated left. That is type 1 mechanics. His AA is rotated right, remembering that that only has rotation. C3 through 4, extended, rotated, side bent right, remembering that in the cervical spine there's only type 2 motion in which side bending and rotation occur in the same direction. In the thorax we have type 1 here, which is one segment. It is flexed, rotated, side bent left. We have a group right here, so you have T2 through 6 neutral, side bent left, rotated right. So you would feel this on the right side, and then if you induced side bending, you would feel that the side bending was more easy to the left. There would be no changes in flexion or extension there. And then you have T7, extended, rotated, side bent left. Again, you would feel this one on the left side. You would feel it, yes, on the left side, because side bending and rotation is in the same direction. This would be a type 2. It would get better in extension. It would get worse in flexion. It would have a facet that was locked closed on the same side that you feel it on. So you would have a locked closed facet on the left side. He's got some counterstrain points. You already know how to treat those. And then looking into the lumbar spine, again, you have a group curve right here. And the point that I wanted to make also about this neutral is you have this type 1 above it, and you have a type 2 above it, and you have a type 2 below it, right? So it would be most important to treat those. This type 1 right here, remember we said type 1s can be compensatory. So although you would want to treat it by addressing those type 2 dysfunctions, you may in effect end up treating it. And this is where my sources are from. Thanks so much for playing along and learning about spinal mechanics.